So this lecture is on ocular ultrasound and how it pertains to emergency medicine and critical care. So what kind of things can be found? Retinal detachment, lens dislocations, vitreous hemorrhages, foreign bodies, and evaluation for increased intracranial pressure. So just a few interesting eye facts. 39 million people worldwide are blind, roughly 6 times with some form of vision impairment. You blink about 17 times each minute, about 5.2 million times in a year. The eye lens is quicker than any cameras. The eye can distinguish up to 500 shades of gray. Just a few facts. So remember, just like any other bedside exam, we have focused questions that we should ask. Is their optic nerve sheath diameter greater than 5 millimeters? And is there any ocular pathology, lens dislocation, retinal detachment, foreign body? So technique and probe selection. So you can use the Vascular Probe that is available almost in any intensive care unit or emergency medicine setting. You want to use high frequency because you want to have high resolution so you can see all this eye pathology. You can do longitudinal and transverse. There are some contraindications: open ocular trauma, paraorbital wounds, and the main one is suspected globe rupture. Some literature says that you can put extra amount of jelly and do it, but it's one of the main contraindications. Minimal pressure can have vagal responses, so patients who are bradycardic or hemodynamically unstable. And the question is whether you should use gel or Tegaderm. My general experience with Tegaderm is when you use it, it's almost harder to get it off. Some of the older patients that you're going to be using it on, they have really sticky skin, and it makes it almost elastic and hard to get off. It does save the patient from having a lot of gel, but honestly, you really don't need to use a lot of gel. A few other things: make sure and remove their contact lenses. It's good to describe the patient eye movements they will be doing prior to starting. I usually have them close their eyes and before I put my ultrasound probe on, tell them, hey, move your eye left and right. These are the kind of movements you're going to be making, up and down. Early on, you might want to use a little bit more gel to get better probe contact, but after you do more of them, you may not need as much gel. The supine position is probably the best. When they're sitting up, sometimes the gel runs off into their face, or I feel like it's a little bit more awkward for them. So a few things about the anatomy, and then I'm going to show you on how you put it on the person's face. And you can also refer to the bedside video on ocular ultrasound that we have for probe placement. So you should see an anterior chamber, a lens, a retina, and a dark shadow that signifies the optic nerve sheath. You should gain adjusted to the structure you're analyzing. So here's another slide of the anatomy, a little bit more detailed. So you can see the cornea, anterior chamber, ciliary bodies, the lens, the vitreous, and then the posterior structures. And you can have pathology at any one of these spots. So remember not to put too much pressure. This shows just the effect of transducer pressure on ocular globe imaging. So if you have a globe rupture, this can actually affect the amount of pressure that is there. So remember, use a vascular probe. This is the sort of image that you get. This is too much jelly probably. And actually what I do is, the jelly is usually cold, even if you can try to get it a little bit warmer. But what I do is I actually put some jelly right here on the forehead. And I tell them the reason I'm putting it right on their forehead is so that they can kind of feel the temperature that's going to be on their eye. I found that has resolved a lot of angst and complaints from the patients. And then you see here, this is transverse section of the eye. You put minimal pressure. This is one of the easier ultrasound ones to do also. So this is what I start with. A little bit more on the technique. Remember, just like when you scan, when you're doing your FAST exam and you're scanning for free fluid in multiple different planes, you want to scan upper to lower poles and temporal to nasal. You also want to do dynamic images with telling the patient to look left, right, up, and down. This improves visualization of the entire eye and actually helps differentiate vitreous pathology from being hemorrhagic versus masses. This is a really good article called Ultrasound of the Eye Made Easy, a comprehensive how-to. It's about 15-20 pages long, has some really good images, and probably one of the most comprehensive papers I've seen on this topic. So lesions of the anterior chamber, lens, iris, and ciliary body are usually seen in ophthalmoscopy. In the anterior chamber, you can see hyphemas. In the lens, you can see cataracts. In the irises, you can see cysts. It's not really helpful for us in the emergency room or ICU, though. For the emergency room, we do see hyphemas. That's probably something important for us. Lesions of the anterior chamber, this is essentially showing you a hyphema that's like full. We actually have different grades of it based on how much percentage of the eye is covered. You can see cataracts. You can see lens malpositions. They're usually posterior, but this is like a traumatic luxation of the lens in a 24-year-old with eye trauma. We don't do a lot of ultrasound on our trauma patients because we're suspecting globe rupture, but I think something important for you to be able to know that you could do if you don't have globe rupture on CAT scan. Because most of our patients get CAT scans when they have acute traumas. You can have lens malpositions. They're also usually posterior, but you can see the lenses down here. More often what I've seen in the emergency room is vitreous pathology. Usually diabetic patients that come in with blurring of vision and we're trying to rule out retinal detachment. I usually see hemorrhage. There are different types of vitreous pathology, probably out of the scope for you. Patients sometimes tell me they say black rain. You can have decreased visual acuity. Ultrasound is really important in this scenario to exclude associated conditions like tumors and detachments. It looks different depending on timing since injury. Here's a vitreous hemorrhage I had, and as I had the patient look left to right, you can see the new hemorrhagic blood just kind of swoosh around. It's important to do because it can help you differentiate between hemorrhage versus a mass versus retinal detachment. Retinal detachment don't do this. Here's vitritis. It's important to look at the structures, subretinal, since this is not well seen on imaging. You can see here. Here's a retinal detachment. You can see this is the retina, and then you can see a retina detachment right here. Here's a hemorrhage, here's a mass. Here's an extrusion of the lens. It's a retinal detachment. Here's actually a globe malposition where it doesn't look the correct shape. This is actually a patient that has increased pressure, where the globe, this is a normal circle, and this is a patient has like an abnormal shape. These are foreign bodies. Here you see the eyeball, and you see a foreign body like a metal piece, and then you see artifact after it. Here's just some more foreign bodies. I wanted to zoom in for you. Then last, I do want to show you some images for screening for ultrasound. So in the intensive care unit, you may want to see if the patient has increased intracranial pressure. There's multiple articles on this. So it's a non-invasive method to detect increased ICP. Increased ICP is transmitted through the subarachnoid space. through the surrounding optic nerve, causing expansion of the nerve sheath. The probe is placed directly over the closed eyelid, just like I mentioned before. It's not great for ruling in, but current literature suggests that optic nerve sheath less than 5 millimeters are excellent specificity for ruling out elevated ICP. 3 recent studies have concluded optic nerve sheath diameter has strong statistical correlation with ICP, but the exact prediction remains difficult. For instance, if the optic nerve sheath is 8 millimeters, that doesn't mean that the ICP is 20 or something. So remember, if you can't find a clear image, sometimes you just need to put a little bit more jelly on. If you can't find the optic nerve sheath, it's probably not enlarged. So on the horizon for optic nerve, we may see it more in battlefield, in the EMS setting. For instance, if a patient has eye injury, if they want to know if the patient needs to go to an eye center versus a local place. Outer space, they may have eye injuries that you can actually diagnose things with optic ultrasound. All right, that's it.